6 years ago, my father had a stroke. He continues to walk, does grocery shopping. And this is all thanks to proper rehabilitation. You might say, well, you're a professor, a neurologist. You surely had a load of specialists, expensive gadgets, machines, and so on. Not at all. Rehabilitation is mostly about the patient's effort and their families. We're not going to talk about it now. God forbid you have to face this terrible situation. If someone you love has a stroke, a traumatic brain injury, it's going to require significant investment, and not just financial, but first and foremost, time, physical, and emotional investment. To ensure your loved one gets back on their feet, can speak, and returns to normal life. It's a hard and heavy topic. More than 500,000 strokes a year, and a third of them, that's a very conservative estimate, a third of people need rehabilitation. Now add post-traumatic the condition after a cranium-cerebral injury, where rehabilitation is also needed, you'll understand that we're getting gigantic numbers, a gigantic number of people who need to recover. What to do? The main principles of rehabilitation. A simple example, a patient came to me, or rather he was brought. And this was not the first time. Speech therapists from our clinic have been working with him for a whole year, so his relatives say, listen, Dotsky, this whole year he's been going to your clinic, we're trying to restore his speech and it's practically not recovering. What? I asked. Is it not recovering at all? Well, no, there are some positive shifts. He started to speak better. First, rehabilitation is carried out until then, until there are at least minimal shifts of the person. The second point, I turn to the patient, ask him, do you want to continue the session? He nodded his head, because he couldn't really say anything. The second principle, when the patient himself wants to continue the rehabilitation process. Result, a month after this visit, the patient's speech began to recover. After another 2 months, he began to speak. Now I have a question for you. Question. What would have happened if the relatives and the patient himself had stopped this rehabilitation? In all European clinics, rehabilitation is a constant process, with breaks for breakfast, lunch, dinner, daytime rest, and night sleep. You too should lend a hand and contribute your strength to your loved one. It's no coincidence that the latest recommendations, say the Canadian Stroke Rehabilitation Guidelines, contain a large section dedicated to working with patients' relatives, that is, woven into these recommendations. Is the notion of the patient's relatives' work precisely working with one's loved one and not so that everything is done only by instructors and doctors? I'm not solely shifting the burden onto relatives. They say that you do everything yourself, without a doctor or exercise therapy instructor, although an experienced instructor is a great help, a huge support in the rehabilitation process. When should you start rehabilitation? There was a time when doctors, nurses, and family members were afraid to move a patient after a stroke, after a traumatic brain injury. Current standing, rehabilitation begins essentially from the first day post-stroke. In fact, American doctors often start the first rehabilitation process 12 hours after a stroke, once all essential life functions are clarified. Life support is not disrupted. We understand that the individual has survived a stroke. So from the first day onwards, we begin to work with them. This is a very crucial point. Like there are golden hours during a stroke. 3, 6 hours, it is the time we can assist our patient, save their life, possibly regain their condition fully. So in the rehabilitation process, there are also golden months. The first 2 months are the most crucial months in rehabilitation. The latest data tells us that what we've achieved in the first 2 months is equal to what we will be able to do in the next 5 years, 2 months, and the next 5 years. That's why the first months after a stroke, after a series of brain injuries, are very important, by the way. It doesn't mean that we should stop the rehabilitation process, but after 2 months, everything's not going very well, everything's going well, and that's it, enough. Goodbye. I'm going to show you the graph of the results. One of the studies here, pay attention to this point. This point is a patient who has regained all functions many years after a stroke. He didn't interrupt his rehabilitation process for many years. He had a complete recovery. He was patient for almost 20 years after a stroke. A complete recovery. Returning to where I started when my dad had a stroke, from the first days when he was already in the ward, we moved him from intensive care. We started with when my colleagues, professors, heads of the department came for rounds. They were astonished to see that my father, with his weak hand, which is weak after suffering a stroke, arranges chess pieces on the chessboard. We engaged him in chess. I made him walk, perform small movements. And by giving a pen or pencil into the hands of your loved one, you create a very important effect. You create not just the effect of rehabilitation, you create the effect of neuroplasticity, the development of a lost skill speech, movement, singing, reading, drawing, writing. This is the development of neuroplasticity. New connections begin to form in the brain, namely, this is the basis of what we call adequate, successful rehabilitation. The brain forms new relationships, and simply put, from a broken, destroyed part of the brain after a stroke or after a brain injury, functions seem to move to other preserved areas of the brain. That is, the brain begins to control this situation and forms new connections due to neuroplasticity. These new connections are why lost skills are restored. Now for some very simple recommendations. We will start with something that might surprise you, but positioning is crucial. Correct posture in bed, even for severely ill patients who might be unresponsive, drowsy, or even in a coma, is paramount. This is the first successful step in proper neurorehabilitation, because if the patient lies curled up or bent, this could lead to contractions in the long run, which should be avoided. Consult with an experienced physical therapy instructor or doctor on how to correctly perform these instructions. Use the proper postures in bed. The second point is nutrition, a classic mistake that continues to be made. Patients should not be fed while lying down. Try it for yourself. Try lying in bed and attempt to eat a bowl of porridge, or even just to drink a glass of water. It won't work, you'll choke. So you have to, at the very least, sit the patient up. Your loved one is in bed. It's best to make an effort to get them out of bed, to sit them next to the bed. Sit next to the bed so they can eat, not in bed, but next to it. Yes, this effort is hard, but it will reward you. Why is it so important? If you start throwing spoonfuls after spoonfuls into your sick relative's mouth, porridge or soup, you can cause a very unpleasant consequence of aspiration pneumonia, because when you lie down and drink water while lying down, you start to cough, sputter, thus preventing food or water from entering your bronchial system, and the patient after a stroke doesn't have this protective reflex, a piece of food. It can clog the bronchopulmonary tree, leading to aspiration pneumonia. The stroke may be small, but the patient could die from the severe issue of concomitant diseases that come with pneumonia. The next recommendation is personal hygiene. This is not only about physiological needs, it's also about dental care and bathing the patient, even in the ward. Sometimes my doctor colleagues experience the first unpleasant hint, the first troubling sign when walking into a ward with severely ill patients, an unpleasant smell of a body that hasn't been washed for a long time. For some reason, they say, or they believe, people think that a person in a critical condition should not wash, bathe, or brush their teeth. This is incorrect. There is a classic rule of 2, 4, 12. Every 2 hours, patients should be turned from side to side in bed. Every 4 hours, they need to clean their mucous membranes. nose, and mouth. Every 12 hours they should be wiped down with a damp cloth, but not using any kind of drying agents. Among substances are bad. An ordinary soft sponge moistened with soap, ablution is performed, and it obstructs. Again, this is a very important and formidable problem. And it hinders the formation of bed sores and infection, because in a seriously ill person, after a traumatic brain injury, after a stroke, the ease of connecting this infection is many times higher than in a person who can move within the ward or room.
Человека, который может передвигаться в пределах палаты или комнаты. Следующий момент.
The next point is the restoration of motor and speech skills. Here you cannot do without the help of an experienced physical therapy specialist, the right. This is a very important point. You don't have to immediately give a ball there, an ice spotter, force the patient to move his arm, press him, which we can achieve in quotation marks, so we can only achieve amplification contractures. This is a very important point, because the patient after a stroke and after a TBI, and this is how spasticity is formed, muscle tone increases, and then you will strengthen this contracture. Rehabilitation is not just about expensive devices or systems. It's not the infamous 1 or 2 weeks in the early rehabilitation department after a stroke. It's a long process that lasts for a very long time already at home, once your relative has been discharged from the hospital. This process should never be stopped in any case. Consistency, continuity, longevity, and correctness of this process is the key to success, guaranteeing that your loved one will be able to stand on their own feet, be able to talk and be happy in this world. Stay healthy, look after yourself and your loved ones.